I will represent the topics that when the A meets urgency, management of the displacement, the arts of aorta in the dissection in the octogenarian K reports in our hospital. About the history evolution, we know that the Georgia 2, King of British England, is the earliest well-known that who died because of acute aortic dissection in 1760 until 1819. René Lames is the first used the term of dissection aneurysm, and until 1954, on-star team include Dipaki, Cooley, and Chris performed the first successful surgical with the dissection thoracic aneurysm, and until 1996, the creation of the Iraq. Iraq is the name of the International Registry of the Acute Aortic Dissection. And today we are followed by a guideline-driven and multidisciplinary aortic team. The pathophysiology of the aorta, how the dissection become further. The first intima tear, they allow blood to enter the aortic wall. They create the von lumen, and the von lumen will dissection to distally and the straight manner. They can be make a lot of complication like tamponade, aortic regurgitation, stroke, or even the ischemia in the renal or mesenteric wrist or limb. We all know that the classification of determine the treatment we through the Stanford classification and Debaki classification. In our hospital, we usually use the Stanford classification. The clinical meaning with us, type A, it usually emergency open surgical repair. Type B with uncomplicated, we optimal use the medical therapy. And type B complicated, we have to do the TIVA or surgery or hybrid. And the acute phase is the first 14 days is the high risk period. Why this disease matter? Because the aortic one, like we know before, the von lumen will progress along the aorta, called rupture, tamponade, malperfusion, or death. And type A is critical because the involvement of ascending aorta made the surgical emergency unless the risk clearly outweigh benefits. So ours matter. And octogenarian, they reduce the physical reserve, more morbidity, higher post-operation morbidity, and function recovery is essential. We can show that in the journal of the session 250-year propensity, we can show that the 40 patients with proximal dissection die immediately, and they increase by hour from 1 to 3%. 20 hour, 70% die. 1 week, 94%. And 5 weeks, 100% people will die immediately. And data from Iraq show that the risk factor development for acute aortic dissection in male sex, age 60, 70, hypertension, previous cardio surgery, or Picobus valve or Marfan syndrome. And other research from the author Park and Lee in the outcome of octogenarian with the aortic dissection, they have not performed the procedure in 28% patient because of the advance of age. And sometimes the obtaining agreement with family is the very big challenging. And other that, the mortality rate in this group is quite huge, from 25 to 37%. And other research show that the rise of the 30-day mortality increased by 8, peaking as 25% in octogenarian. And we can see that in that table, we see from the Iraq data. So the type A with medical therapy, in hospital mortality will be 60, and then more than a half. So we can show that the residual mortality remains substantial. And type A, dissection carry very high mortality without surgery. However, the operation risk rise with age. So if we do the operation with the patient over 18 but be individualized, we do not deny surgery based on the A alone, but we have to elevate the frailty, the neurology status, the organ failure, the anatomy, and the patient goal. Because the patient over 80 years old, they is very unique to vulnerable, like because they reduce the reserve and the comorbidity burden, like hypertension, CAD, CKD, COPD, or the atherosclerosis aorta maybe have a high risk of stroke or the ischemia of the vessel. And the post-operation is a lot like infection, respiratory failure, or loss of independence. So the goal is survival and meaningful recovery. We have the diagnostic pathway from the symptom like a sudden chest, bad pain, syncope, dyspnea, shock. But in the patient more than 80 years, maybe the pain may not absent or poorly describable. Unexplained shock, acute neurologic deficit, or dyspnea should be raised suspicion. With the patient with high risk, we immediately do the imaging like a CT, or if the patient not unstable, we can do the TEE or TTE for civilian. And we classify the type of the patient in the outpatient dissection and treat by surgery, TIVA, or medical. In the Stanford type A, we can surgical management by remove the primary tear, prevent the rupture, create the true lumen, and arrest the valve, the roots, the corollary. Like we can do the altis replacement in ascending aorta. We do the hemiarch, total arch, or do the bento procedure if it needed, and if we can also do the valve repair replacement. The AS more than 80 surgery is life-saving, not maximalist surgery. Minimize the bypass time and the arrested harm, and prioritize the neurologic and organ perfusion. The type P, if not uncomplicated, we can optimal medical therapy and civilian. But the complicated type B, we do the TIVI if suitable, or if not, we can do the open or do the hybrid. Post-operating medical management, we have to hemodynamic control, like use beta blocker, avoid BP surgery, or assess the hypertension. We do the CTA to monitor the residual volume, outlet diameter, and anastomosis. The early complication we have to follow, like a bleeding, the tamponade, the stroke, the respiratory failure, infection, or arrhythmia. And the geriatric recovery, like delirium prevention, nutrition, mobilization, and fall prevention. The decision making in patient over 80 benefits more likely. We have to have hemodynamic stability, favorable anatomy, or independent beta function. Core decision is A alone should not determine the treatment, but have to do the balance survival function, anatomy, fatigue, and patient goal. But remember that the risk may dominate because the prolonged shock, multi-organ failure, severe stroke, or the poor baseline function. I had one case. Is that the patient, male patient, 86 years old, with a history of diabetes, COPD, related with the smoking and poor controlled hypertension. They admit our with the sudden onset of dyspnea and chest tightness. He initially transferred from the emergency department, and we do the CD and show that he had the acute aortic dissection with Stanford type A, compression with the of the brachiocephalic artery by the volumen, and echocardiography show that he have the hemopericardium, while the cardiac function we preserve with the AR is mirror. The patient under urgent pre-operative workup and preparation for the urgent surgery in 2 hours. How do we perform that? First, we have to do the medial sternotomy like classical, the arterial cannulation side, which considering through the altitude condition. Usually, we will do in the right axillary artery if the patient not suitable for doing ascending aorta. And after that, we do the method cannulation and run the CBB and do the deep hypothermic until the temperature around 20 or 22. In this patient, In this patient, we open the medium sternotomy, open the pericardium, and suddenly the ascending of the rupture. The patient will be have the the blood pressure is very low, and we starting use the cell saver and the uh, drain session to cannulation in right atrium and started to try to clamp in the arcs of aorta and do the hypothermia. After that, we arrest the heart to the coronary ostia, and we use the uh, do the bilateral selective separation perfusion and to protect the brain. And we open the aorta to see where we have to we do the partial or total arc replacement. The ascending of distal repair is decided based on the location of the entry tier. In this case, we have the entry tier in the ascending aorta near the brachiocephalic artery, but the volumen extended into the RCCA and LCCA. So we have to do the hemiac replacements in zone 2. This is before and after. This is the CT before we do this. We see the volumen in the ascending aorta and a lot of blood inside the pericardium. And after that, so remember, we not maximalize the surgery we had tried to do to save this old man. So the total operating time is more than 200 min. The CBB time is 135. After this cross climbing time is 70 min, and the arrest horse is 4. Arrest is circulatory arrest time is 40. The selective cerebral perfusion time is 35 minutes. Duration of micro ventilation is 2 days, and ICU length of stay 7 days, and total hospital length stay 2 weeks. The blood transfusion is 2 pack, and the drain output is around 250 millimeter, and the patient have no renal failure, hepatic failure, and the cardio function were preserved. The patient after that have 2 days and with the mechanical ventilation and successfully extubation. And post-operative, he underwent the pulmonary rehabilitation and respiratory physiotherapy. And we keep him in ICU in 7 days, and 14 days after that, he have left the hospital. And the patient have to maintain the medical therapy. The key takeaway that's the acute aortic dissection is time critical cardiovascular surgery. And the Stanford type A generally require the emergency surgery to repair. Type B strictly medical unless the complicated. The patient over 80, high mortality and high post-operative morbidity. But the best care combine fast diagnostics, individualized treatment, and structural post-operative recovery. Thank you for listening.